Thank you. Good morning, ladies and gentlemen. It is our honor to chair this session on current status and future perspective of hepatic resection. I'm ST Fan from Hong Kong. My co-chair, Professor Aoki and Kaido from Japan. We have actually three speakers this morning. Professor Xu from South Korea cannot attend, so we'll start with the first speaker. Um, Professor Aoki will introduce the first one.
Okay, thank you. Good morning. I'm Takeshi Aoki from the Shorin University in Tokyo, Japan. And now I'm going to introduce the first paper. And the first paper is title and ICG fluorescent imaging and assisted laparoscopic anatomical hepatectomy using the inside out the transaction. The Professor Itano, please.
Thank you, Chairman. I express sincere gratitude for the Congress Chairman, Professor Shina, to give me a chance to have a presentation in this session. To get the good outcome of liver surgery for liver malignant tumor, especially HCC, anatomical liver resection should be done precisely. So today I'm gonna talk about how to transect the intersectional plane precisely during the anatomical liver resection. I have no COI. So let's think. So how to transect precisely on the intersectional plane of the liver without cutting the crossed peripheral branches. So in the conventional anatomical liver resection, usually we block the blood flow or dye injection method and get the demarcation line. Then we set the transaction plane connecting these three checkpoints because the intersectional plane is not visible in the liver parenchyma. Then we start to transect from the peripheral part and to the intersectional vein. Then sometimes we cut the liver peripheral Grusonian branches, which you bump on the way. Then finish with the flat transection plane. And this is the transection plane said to be good surface, but it is good. So I think this is too flat. So as you know, the hepatic resection surface is not so flat, and the hepatic vein are not a factor in defining a resection surface. Back to the definition of anatomical liver resection, it's the resection of the entire hepatic parenchyma tissue supplied by the portal venous system during draining the tumor tissue. It means hepatic veins are not relevant relevant to the area of the resection, and Grissom should not be cut if possible on the way. And look this kind of excess resection ischemic area. This might cause the complication. So please remember how to handle this kind of the object. So I think you don't split this kind of object from the peripheral according to your sense. You split from the root side. So filling up from the root side, right? So you can get the location of the root root of the Graconian pedicle, corresponding Graconian pedicle, and the root of the transection. You can do the accurate anatomical liver resection like this. So when you do this kind of the method, you don't need the demarcation line. It means you don't have to do Graconian approach or dyeing method. You don't need to look for the intersectional vein. You don't have to cut the Graconian branches on the way. It means reduced by leakage. So where is the root of the Graconian pedicle? Here. So you can see the root of the Graconian pedicle is on the theorem, at the theorem, like this. Then you can start the transection from here, like this. So next, you have to know the precise transection route. So I can show the this kind of method. So you can you can see the transection route by checking the ramification of the branches of the Graconian pedicle in the laparoscopic view like this. You can see these kind of branches. So at that time, you look for the chicken crow sign right here. This is the sign of end of the Graconian branches, and the lines connecting these signs indicates the precise transection lines. So interestingly, you couldn't realize the chicken crow until now in open surgery. It's because of the shape of the ramification of the Graconian pedicle. So if you see from here, this looks like here. But in the laparoscopic view, you can recognize the boundary like this. So the tips of a transection, you put the tip of the cursor here, then like this. Another tips is practicing technique. If the one Graconian branches go extended to the another side of the ribbon parenchyma, you grab these branches by forceps and pulling during the dissection. Then you can resect the whole branches. This is the bracketing technique. So you can see the branches. Grab it at the pulling and dissect at the tip of the Graconian pedicle right here. So the method I talked is called inside-out transection by central approach. This completely suit for the concept of the anatomical liver resection. you start approach the root of the corresponding Gaussian pedicle and dissect inside out to remove all branches. So this is a summary. Start directly from liver parenchyma transection from the root to the corresponding Gaussian pedicle. You don't need the demarcation line. You don't need exposure. You don't need to expose the intersectional vein. As a result, the intersectional vein is naturally exposed on the way. And you don't need to cut the Gaussian branches on the way of transection. And the corresponding Gaussian pedicle can be cut when inner space is made. So you have to be careful to misunderstand of the branches on the way of the inside out transection. If you don't cut from the root from here, you sometimes unintentionally go into the area in between, like here. So to avoid this kind of mistake, the ICG fluorescence imaging assist method is the good option, like this. You can see the rough direction by the ICG fluorescence image and check the chicken crow like this. This is a video case, so I'm sorry. This is not the HCC, but chorometastasis case. So laparoscopic extended posterior sector resection plus S5C area. So this is the preoperative image. So like this. So resection of this area. Cut the posterior branches like this. And you have to dissect the S5C like this. So after the mobilization of the right lobe, you start to transect liver transection from the root of the posterior branches. You can see here. So you check the chicken cross sign and go transect to the direction with less resistance and encircle the posterior branch and block. So you can see the demarcation line. Here. So start to transect inside out to the direction with less resistance and see this kind of small branches. So you don't check the demarcation line on the way. This is right hepatic vein. Then after you can get enough space for you transect the posterior branch. And then this is G5C and crump. Demarcation line extended to the tumor in the S5C. So ICG was injected. You can see the boundary clearly by the ICG fluorescence image. So continue the transaction according to the boundary by the ICG image. Here, this kind of complex transaction, so ICG image is very effective. During these kind of parenchymal transaction, so clipping and dissecting of the Gersonian branch is 0. So dissecting the IRHB, then finish. Okay, ICG fluorescence imaging assisted inside-out transaction enable us to perform precise intersegmental transaction in laparoscopic anatomical liver resection. Thank you for attention.
Thank you so much. Great presentation. Are there any question and comment is from the audience, please? Okay, I have one simple question.
Okay.
Professor Itano, is you showing us is very beautiful. The anatomical resection is an MIS setting. I think it's I definitely agree with you. It's an ICG fluorescent imaging is very useful for identifying not only a liver surface but also the transection plane when you perform the anatomical liver resection. So my question is sometimes the negative the staining method could be gradually contaminated and due to the collateral circulation due to single portal vein clamping, and also the presence of the collateral aberrant circulation. The feeding is an undesired segment. So my question is when you perform the negative staining method, is how much dilated solution in ICG should be used?
I usually use 0.5 per body. Millimeter
Okay.
per body.
So you are clearly demonstrated as is you check in a chicken claw the sign, and even if you use an ICG fluorescent imaging, but it is ICG fluorescent imaging is not disturbed to check in a chicken claw sign and on the transaction plane.
Because so like I said, so sometimes we understood the transaction plane during the inside-out transaction, but also the ICG image, like you said, so sometimes a different real transaction plane because it's ICG imaging show the boundary of the blood flow, right? So I checked the rough direction by the ICG image, and the point of the transaction, I checked the chicken claw. This is the best combination.
I see. Okay. I see. Okay. Do you have any comment or the question is from the audience? So time is the 1 minute is in the left, and then do you have any?
So
Yes,
can I
please.
comment? I'm Yuji Imuro from Yamanashi Central Hospital, and thank you for a nice presentation. And I'm just wondered, how do you keep surgical margin in your technique? If,
okay.
especially in case of the tumor contain some poor aggressive factors like ICC.
Yeah, I always, also use intraoperative ultrasonography, but usually I set the transection area preoperatively to wrap up the tumor completely. So usually I do the surgery according to the preoperative planning, and as a result, we can get the enough surgical margin.
And one more. In your technique, you use QSAR.
Yeah.
I'm also familiar with the QSAR, but how about crush clamp technique?
Yeah, it's difficult for to do by crush clamping technique.
Because robotic surgery becoming a very prevalent in these days.
So now I'm trying another method using the robotic arms, and also try the CUSR assisted robotic surgery.
Thank you.
Thank you. Thank you so much. Thank you. So our next speaker, Professor Kwang Ming, he's from China, Guangzhou. He will talk to us about will adjuvant chemotherapy post-curative treatment for HCC be a paradigm shift.
Thank you, Chairman. I'm Dr. Ming Kwang from the First Affiliated Hospital, Senior University, Guangzhou, China. And it's my great honor and pleasure to be invited by Dr. Shina to attend the episode this year. I would like to talk more about surgery. So my topic is surgery leading MDT, multidisciplinary team model for treatment of hepatocellular HCC. I have no disclosure. HCC contributes to 90% of prime liver cancer, and 45% of new cases in the world are in China now. And HCC ranks number 2 mortality rate in cancer and in China. So that's a major threat for Chinese population. According to the BCLC guidelines for only very early stage and early stage HCC should be performed by the resection or other curative treatment, transplantation, and local ablation. Where in China, surgeons are more aggressive, so we can see the nearest CNLC guidelines, and for surgery can be applied for stage 1A, 1B, and 2A as a first-line treatment. Also, even for 2B or 3A, they can also choose surgery. So, but however, nowadays you can see because the majority of our patients are diagnosed as a stage C at the first diagnosis. So that's why now the 5-year OS in mainland China is still 14%. That's relatively lower than that in Japan, and Korea and other countries, because there are more early stage HCC detected in Japan and Korea. And we have to face similar challenges worldwide. 2 of them majorly. Even after curative surgery and curative resection or ablation, the local and after this local therapy, 5-year recurrence rate could reach 70%. And also now in the era of TKI and immunotherapy, the single use of this therapy for those advanced stage cases, but the ORR less than 20%. So we should do, that's the question. What should we do? Now we have minimally invasive surgery, and now we have robots. Soon we'll have a nanotechnology. But I think we still have to consider about beyond surgery. We think about combination with the imaging technique, genetics, genomics, even AI. So that's I think about 3I. The first, interdisciplinary. So we should cooperate with more people to conquer in this battle against HCC, an innovative technique, innovative vision, and also integration system. So this is what I want to talk today. This is we called a multidisciplinary team, leading by surgery, cooperated with oncology, interventional oncology, and even scientists. 3 ways. First, of course, minimum invasive surgery should be done. The second, we should have the vision of precision medicine. That means we know more about the tumor biology. The third, combined treatment. Well, for the minimum invasive surgery and for the laparoscopic liver resection, LLR is now quite common. Everyone, we know the advantages of this surgery, minimum invasive, okay? And now the indication can be applied to most cases as open hepatectomy after the well training and accumulation of experience as laparoscopic liver resection. And also there are some there is compared to open surgery, and laparoscopy liver resection has less complications. And for the very important thing is oncological outcomes. Both are very similar. So, but much safer and with a very equivalent oncology outcomes. And there are many publications, especially from Japan and Wakabayashi Sensei, many other professors. There are show us how to perform safely laparoscopic liver surgery, hepatic inflow control, deletion approach, hepatic outflow control, and to perform anatomic, non-anatomic resection. And now there are recent survey in Europe, and more than 100 surgeons in 24 European countries. You can see now the minimum invasive liver surgery, which including laparoscopy and robots, comprise about 1/3 of liver resection in Europe, as a recent survey. And also laparoscopy MILS is still twice as robots. Oh, this is what we can see. Now we can see this percentage of the MILS is increasing. Well, that's in my center. We can see especially for the ratio of microinvasive and liver resection, the risk increased just in the past 5 years, and from 46% to almost 66%. 20% increase. So that means it has been widely used and with very low post-OR complication rate and infection. So this is our number. And now in our center, we have done many technique improvements, such as a 3D vision before the surgery, and also functional imaging to check the liver function, and also robots approach, and IOU, intraoperational ultrasound, and ICG guiding. And also we use ablation-assisted liver resection. I want to show you several examples. The first one is a tumor right here, just in the middle of the liver. So the 3D shows the liver hidden, right here, and the right anterior and posterior hepatic veins just hiding in the angle. So this is our glycine approach. We use harmonic knife. We don't use Cusa. So this is it. So that's why we combine that with 3D vision. We can easily, dissection each branches around the tumor. So one by one, we can see with a very good control of the central vein pressure, and also there is no blood loss. There is no hemorrhage during the surgery. And then dissect the liver parenchyma. So we are long continuous observing of the 3D vision during the OR. We can see we dissect each branches around the tumor. Finally, this is portal vein system. Hepatic vein. Finally, you can see around all the branches, see, that's where we removed. So this is our Gleason approach. And then we also use real-time intraoperational navigation. So when we deal with this right portal and hepatitis portal vein, now I'll make it faster. So this is software here. We check it. When we show, we use a 3D merging here. Then we will show which one. Oh, this one, yes, is a track of the right portal vein. Okay, so we use this continuously in the OR, and we have the on the screen. We can see this, and then that will help. Okay, we bring the lever back right here, and when this can help us to do more precise procedure during the OR. Also, we performed ICG guided the resection and like domino. Okay. Quite similar procedure. I will ignore this because Dr. Imada have showed this. And finally, we can see ICG guiding around. This is a tumor where it here. And also, I perform for, in some cases, this is a patient with severe liver cirrhosis. With a liver cirrhosis, but there is a small tumor right here in the segment 5. But this tumor is abutting to the abdominal cavity. So unfitable for tumor ablation right here. So we use ICG, and it shows the tumor here. And we want to, perform the safe, because this liver cirrhosis is very clear here. So we use a microwave ablation to calculate the tumor margin 1 centimeter, 2 centimeters away from the tumor. After calculation, we resect it. And there is no, you can see, no hemorrhage, and the whole tumor will be removed in this cirrhosis. This is what I've done. And also we perform laparoscopic microwave ablation for the portal vein ligation for stage hepatitis, ARPPS. I just do some modification for that. So this is a huge tumor, right? And we have to do stage hepatectomy. So first of all, this is a dissect of the right portal vein ligated. That's a regular for the, and then see, this is intraoperational ultrasound. You can see that is clearly we can see the medial hepatic vein, and to the left side we find it, we mark it, and then we insect microwave ablation. See right here. Just we can put it right here from the surface to the 1.5 centimeters away from the IVC. It's very safe for a surgeon. And then we calculate the whole parenchyma, like this one. And also from the visceral side. So this is after. This is just the first stage operation done. And 2 weeks ago, 2 weeks later, we perform MRI. You can see that clearly the partial detection from these two part of livers. Then we perform second stage laparoscopy surgery. Still very severe adhesion after we can find it. But this is a regular and procedure, laparoscopy right and hepatectomy. And this is calculated area. Okay, then around and the to the right side of the microvascular invasion. Medial hepatic vein. We use a golden finger. Dissect it. It's a right hepatic vein. Finally. Okay. just the IVC. And we also perform robots. And for this tumor to the left side of the liver, we perform robotic assisted liver hepatectomy. And this is a robot surgery. I do think the robot surgery has 3 advantages, especially in this case. It's very convenient to use a robot's arm to deal with the dissection of the portal hepatis and to dissect any lymph nodes or deal with the vessels. See, there's a portal vein. And also the second advantages is IOU, ultrasound, very convenient to use. And also the third way is suture. I just suture the left the hepatic vein. Very convenient and very quick. Then that's the regular left hepatectomy. And that's I won't show the detail here because that's easy for everyone in this room, I think. That's easy to do. So that's the robots. So we have done many kinds of operations in our center, and we have almost 3,000 cases of resection a year. But we're dealing with surgery. We're dealing with HCC. That's a cancer. So I really enjoy the word from Dr. Blake Candy, the former president of SSO, and in the world of surgical oncology. Biology is king, selection is queen, technical maneuvers are prince and princess. That means nowadays we must understand the tumor biology. That's even we are surgeons, but we should know more about the cancer. That's our HCC program in my center. Biology-driven HCC program. We established MDT team, and we established a high-quality clinical database and a biobank. And also we're using cutting-edge multi-omic sequencing technique and artificial intelligence. And also we back to the bed and perform multi-center clinical trials. So this is our MDT team, leading by surgeons, and our partners are interventional oncologists, radiologists, oncologists, and also the pathologists, scientists. We work together. Not just it's like we have the MDT clinic. We see patients in clinic together, and we have MDT discussion, and we have clinical club and MDT many meetings. We share our graduates together. So work as a real team. So in the past 5 years, we established the clinical database for more than 13,000 for almost 500 cases. And also for each patient, each resection, we perform your standard 7-point sampling protocol. That means 7 points around the tumor. And we gathering every sample, including the tumor, the liver tissue, and microbiota, many things for every patient. And we match this clinical database with the pathology finding and imaging profiles. Then the follow-up rate 92%. And also, this is very interesting. So after this, we use a 7-point sampling procedure, and we perform the prospective study. To our surprise, we find for more than 1,000 cases, we find an MVI rate. That means the microvascular invasion rate 1 centimeter away from the tumor could reach almost half of our patient. So that's much higher than our formal report. That means just a 1-point sampling, and that was only less than 15%. So I do think this will help us understand why there are such a high recurrence after the resection. And also we perform the genomics, transcriptase, immune microenvironment, RNA epigenetic studies to review the tumor biology. And this will really help us understand why the tumor will recur and how they occur. For example, in this study, we find for in the large HCC, the proliferation pathway is often active. But for the small HCC, that means less than 2 centimeters in size, the immune pathway are quite active. So we can really combine the therapy and anti-PD-1 therapy together. And also, in the recent study, we found there are two kinds of the recurrence for HCC. One is truly recurrent, and the patient has this recurrent tumor. They share the same gene with the original one, and also this contributes to 75% of our recurrent patient. And another one is de novo recurrent, and this de novo recurrent HCC is usually very sensitive to immune therapy. So this distinct tumor ecosystem in truly and de novo recurrent HCC, that means we have to deal with the patient with a quite different strategy after the surgery. And also that's why the Nature review asked me to write a review for them, because after the surgery, RFA, radiation, or lymphadenum intake, there are many changes for the tRNA level. tRNA modification, 3 major ways to change it, and this will cause tumor cell growth and lymphatic resistance and even anti-PD-1 resistance. So this will help us to understand if now we have finding maybe the META1 or META6 could be the biomarker next generation. But this understand how we'll deal with this patient after the surgery. And also we integrate the images with pathology images, yes, clinical information, and use the AI analysis to guide the treatment decision and predicting treatment prognosis. And finally, we must go back to bed because we are doctors. So we find the recurrent and multifocal HCC have microenvironment heterogeneity, and combined therapy might have higher tumor response rate. So we design different clinical trial: adjuvant therapy, immunotherapy, local plus systemic therapy together. So we try and we saved the South China liver tumor group, SART, including 32 large-scale hospitals from South China, where do the multi-center studies. So first, we tried for larger tumor, more than 5 centimeter tumor in size. We have triple therapy, including anti-angiogenesis, rifamycin, and TACE, and thermal ablation together. And then this triple therapy prolongs OS by 56%. And also, after curative resection or the ablation, we collected the sample, we found the mutation, and we used a new antigen DCCTR and to treat the same patient. To our surprise, that cellular immunotherapy had a much higher response rate, 70%, and patient response well to treatment had much better survival. So that means adjuvant therapy could really, immunotherapy could help. And we also performed a study launch. That means for the unresectable advanced HCC, we use lymphadenum plus TACE. That is because this is randomized design clinical trial against lymphadenum alone. So this combined therapy has a much higher response rate and better prognosis in advanced HCC. And it's very good thing is that among them, almost 20% of this patient can receive a curative resection after downstage of the tumor. And this is oral presentation in ASCO GI 2022. And also this is our recent study for the primary HCC with portal vein embolize. And we, after surgical remove the portal vein embolization, and we give the patient adjuvant therapy such as sorafenib plus TACE and against VS, sorafenib alone group. And we found this sorafenib plus TACE as opposed to operative adjuvant therapy in HCC patient with the PVTT resulting much longer RFS and OS. And so compared to sorafenib alone. So this is also last year we invited to ASCO GI, give a presentation, and our study just being accepted by JAMA surgery this year. And also for those patients who received curative resection in stage A, stage 0, but if the histologically confirmed micro MVI, and then this patient should be considered with high risk and recurrence patient. So we gave them adjuvant therapy and TACE plus sorafenib and VS and TACE, because this two study has been done 4 years ago and just a follow up. And this also we find is very interesting, and the OS in the combination group much better than the single use of the TACE. Okay, so this study also just accepted by JAMA Oncology. That means the combination therapy shows very good results than the single treatment. So, and also this year we performed another study. We use adjuvant radiotherapy, IMRT, they can really, for the patient who received the narrow resection, but with a narrow surgical margin, that means less than 1 centimeter. So we use adjuvant radio therapy, and this adjuvant therapy can really improve RFS and for the patient. This also I was invited to give oral in SQGI this year. So it seems this is our thinking. This is a new strategy. For surgery leading MBT model, if we focus on the minimum invasive surgery and with the better understanding of tumor biology, precision medicine driven research should be done. And we should ask help from other doctors. We should combine everything together. Finally, in our center, we can see the improvement of OS of HCC patient, the 5-year OS for primary HCC anal gum curative resection, and more than 5,000 cases. And we can see compared to 2006 to 2010, and from 2016 to 2020, you can see the 5-year OS really 20% of increase in our center. So I think this is is maybe immature. This is our investigation, our thinking beyond the simple surgery, beyond the technique. We should have a new strategy, but the surgery leading. The reason I see surgery leading because we can have all the specimen collected and we cooperate with all experts in other areas, including scientists. So this is my brief introduction. Thanks for your attention.
Thank you very much. Thank you. Thank you for your excellent presentation. May I start asking you about the technique of the apps? You use microwave to coagulate the transection margin. Do you actually transect the liver after you use the microwave?
Yes. No. You mean stage 1?
Later, in the second stage?
Yeah, in the second stage, yes. We resect it.
So why don't you cut the liver in the first stage after the microwave?
Because the complication rate very high. We know ARPPS, even in the stage 1, if we cut the liver parenchyma, there's still some kind of unexpected complication. But we just coagulate the tissue with a microwave, then the operation very quick, less than 1 hour, and the blood loss average less than 50 milliliters. And then very safe for the next stage. The patient will recover 1 day later.
But would you worry that the operation is not complete?
Yeah, so that's why there are many techniques inside. That means for insection side, just 1.5 meters away from each one, and you must put the needle, the tip, to the 1.5 centimeters away from the IVC. Yeah. That will help you really coagulate. About 1 to 2 minutes of coagulation for one side. It's okay, done. We have done that in animal study.
Yes, thank you.
Thank you.
So is there any question from the floor? And Dr. Imuro, do you have any comment?
Thank you for your beautiful presentation. I'm Yuji Imuro from Yamada Central Hospital. And I'm interested in adjuvant therapy after curative resection. And I agree with you. Many recurrence come from intrahepatic metastasis from primary HCC. So you presented microvascular invasion is a good biomarker in clinical situation. And I wonder, can you speculate other biomarkers from your conventional data?
Thank you. That's okay. Excellent question. That's what we want to, because when we take part in participating in the STORM study 20 2015. After resection, we gave the sorafenib, but nothing happened. It's an active study. So at that time, we think about how to select the real high-risk patient. And according to recent study, MVI, yes. And you must be familiar with the recent publication, recent study, the only one in the world that shows a positive and result of the adjuvant therapy. And so I think it's maybe the tumor size more than 5 and multiple tumor more than 3. And but that is not the real biomarker. And MVI, I think, and according to our experience by far, is the most reliable one. And that can really help us. And also there are some liquid sequencing, liquid check, and for the BBMC check, maybe there are some biomarkers, many publications, but none has been confirmed as one. So by far, I do believe MVI is quite possible, and also multinodular. I believe that. Thank you.
So another question: do you have transplant surgeon in your team?
Yes.
Yeah, you have.
We have.
Yeah, so you consider transplant as one of the multimodality treatment? Yes.
Yes, that's one of the best because of shortage of donor. That's the only problem.
So another question is about the 7-point sampling. You demonstrate very high positive rate. So with that information, how will you determine the tumor-free margin nowadays? How big or how wide is the tumor-free margin you consider sufficient?
At least 1 centimeter.
Okay.
So because the 1 centimeter MY positive rate is 47, and 2 centimeter is only 13%.
Okay, thank you. Thank you very much.
Thank you.
The next speaker is Professor Dong-Sik Kim from South Korea. The title is Surgical Approach to Hepatic Cell Carcinoma Located in Difficult Locations. First of all, thank you for coming to Japan in spite of tough condition in South Korea. So please start your presentation.
Thank you very much. I would like to show my gratitude to the organizing committee for inviting me to this wonderful meeting and wonderful city and season in Kyoto. My topic today is a surgical approach to hepatocellular carcinoma located on difficult locations. Nothing to disclose. So, as a surgeon, when we make a decision to resect HCC, the decision should not be based on the technical terms. The reason that I talk about this is because it's obviously the minimally invasive era. So, also for my personal clinical practice, I would say about 70 to 80% of my liver resections are being done by a minimally invasive technique. But when we decide to resect, especially the HCC, the resection about decision to resect should not be based on technical term. It should be based on likelihood of long-term overall and the disease-free survival and the risk of postoperative morbidity, mortality, secondary to liver insufficiency, and also risk of developing complications secondary to aggravated portal hypertension, which is well described in the literatures already. So it should be based on chance of long-term survival rather than a technical aspect of resection, especially because the HCC patients usually have the underlying liver cirrhosis. So for the surgery, we need to optimize the patient and the whole procedure, surgical procedure for the best outcome. And Especially, we need a good evaluation of liver function, preoperative liver function, and even estimated remnant liver function. And we also have to decide whether this surgery can be best accomplished and served for the patient by open or laparoscopic versus robotic approach. And also, we need to think about anatomical resection versus non-anatomical resection. And oftentimes, the location of the tumor, whether it's close to major hepatic vein or close to big hepatic inflow, is important determinant. And also, we need to think about the tumor biology also. So it's well known that the anatomical resection is preferred. I mean, I cannot say anatomical resection is absolutely better than non-anatomical resection, but most of the surgeons actually prefer to do anatomical resection if we resect for the HCC, and the theoretically anatomical resection can provide a better local tumor control. But anatomical resection has a tendency to remove more liver parenchyma. So that's one thing that we have to remember when we decide for the surgical strategy. And for the laparoscopic liver resection, when the tumor is located in this posterior superior segments, usually segment 7 and 8, these are well known to be as an unfavorable location. So when tumor is exclusively located in this area, we may choose like a big right hemihepatectomy, but that will sacrifice large volume of liver parenchyma, which is not affected by the tumor. So oftentimes these tumor located in these locations are, if we do in a laparoscopy or minimal invasive approach, oftentimes we have to use transpleural port and some unusual decubitus positions, but still it ends up with a non-anatomical liver resection. So if I want to do some this type of non-anatomical resection, then I often use left lateral decubitus position and also put intercostal port, small intercostal 5 millimeter transpleural port, and then it gives me a lot of more freedom of manipulation, and then actually we can just simply close the diaphragm at the end of the procedure without worry about pneumothorax after surgery. But in a normal, usual conventional cases, I prefer to use this kind of a position. And because the big theme of this session is about also talking about future liver resection, the robotic surgery also clearly has some role in the liver resection for HCC. It's gaining more and more popularity as of now, but regarding to the tumor located in posterior superior location, at most of the robotic surgeon at this point would probably prefer to do right hemihepatectomy instead of limited resection because of the difficulty of approach, and also for the suboptimal liver parenchyma instrument. So let's think about these cases. If we have tumors like these in segment 7 and 8, because these are small tumor, but it's actually touching the right hepatic vein. And if we if we do not resect the right hepatic vein together, then the margin will be positive or very close. And this tumor located very deep and also touching the IVC. And this is very big, and whole segment 7 and 8 are occupied by the tumor, but if segment 5, 6 are saved and have a limited liver function. In this case, we can think about right hepatectomy. It's technically easy, and we can easily perform using laparoscopic or minimally invasive technique, but unnecessary removal of normal liver is inevitable. And if we want to do segmentectomy 7 and 8, and then sometimes concerns about congestion in segment 5 and 6 is one problem, because right hepatic vein has to be sacrificed, and segment 5 and 6 may lose their outflow. In these situations are especially concerning when remnant liver function is marginal. So if the patient has a significant right inferior hepatic vein, about 20 to 24% of patient has a thick right inferior hepatic vein. And in this case, how to do is well described by Professor Makochi in 1987. So the right hepatic vein can be sacrificed without much concern, and the right inferior hepatic vein can serve as outflow for remnant segment 5 and 6. So these are the case that we did, and just right hepatic vein just simply sacrificed without no reconstruction, and there was no much problem after the surgery. And yeah, I did this with open case, but this case now probably many centers can do under the minimally invasive approach, even if it is segment 7 and 8. Still, many centers can provide minimally invasive approach recently. But if patient does not have a significant right inferior hepatic vein, in the past we did this kind of surgery. As you can see here, patient is cirrhotic, and right hepatic vein has to be sacrificed, and patient does not have a right inferior hepatic vein. Then we're concerned about congestion. Then we used vascular conduit connecting the middle hepatic vein and the right hepatic vein. But no matter how short we make it for during the anastomosis, after the anastomosis, once we put the liver back in to the abdominal cavity, then this becomes too much relaxed and then easy to be kinked. And early after operation, the thrombus can happen, and then stent has to be placed. We experienced a couple cases of this. So then, as shown in this picture, we just removed the right segment 7 and 8, and then without using vascular conduit, just fold the liver like this, and then directly connect re-anastomose remnant middle hepatic vein and the right hepatic vein stump. So let me just show some videotape of this. So this patient has pretty large tumor in the segment 7 and 8, and relatively small left lobe. So we were concerned about just doing right hemihepatectomy. So right anterior and the right posterior glissons are isolated separately and being clamped to see the demarcation. And after the mobilization of the whole right lobe, this right hepatic vein is isolated here. And under the ultrasound guidance, I'm checking the branching point between segment 5 and 8, and also 6 and 7, then marking the demarcation, expected transection lines like this. So the liver parenchyma transection is being done under the using CUSA, and inflow to G8 is being isolated and ligated here. And the middle hepatic vein, right hepatic vein is identified and temporarily clamped using hemlock. And also the glisson to segment 7 is identified and isolated and divided. And small branches to caudate are being, and this is V8 draining to middle hepatic vein, which is sacrificed, and right hepatic. So the stump of middle hepatic vein is now open in preparation for the anastomosis, and right hepatic vein is clamped and specimen removed, and we just simply fold the liver and approximating the two ends of the hepatic vein, and just simply direct anastomose with the 6-O-Prolin, and then reperfuse like this, and checking the flow under the ultrasound, and showing good patency of the liver. So these direct reanastomosis of right hepatic vein after bisegmentectomy 7 and 8 is several advantages over technique of right hepatic vein reconstruction using artificial graft or cryopreserved cadaveric vein. Only one anastomosis is required instead of two, which is easier and quicker, and avoidance of using foreign material. And also it decreases the risk of kinking or distortion of anastomosis when the remnant liver is placed back in position. So this technique could preserve segment 5 and 6 without compromising in oncology principle while maximizing remnant liver volume and function. So we reviewed our series and collected our case of bisegmentectomy 7 and 8. Sometimes we preserved the right hepatic vein, sometimes we sacrificed segment 7 and 8, and the other option for this was probably the right hemihepatectomy. So we think that the right hepatic vein sometimes can be easily resected without much concern. Sometimes it can be reconstructed with a conduit in patients with a right hepatic vein. So HCC located in posterior superior segments can be challenging cases. And optimal oncologic outcome with the functional preservation should be the prime interest in the process of choice for surgical technique. And even in the era of minimally invasive surgery, open approach has clear role and indications even in the era of minimally invasive surgery. Thank you very much.
Thank you, Professor Kim, for your excellent presentation and beautiful videos. Are there any questions from the audience? Oh, please, please, Eguchi.
I'm Eguchi from Nagasaki University. Thank you for your nice video and advanced technique, actually. And I have two questions. Because of the difficult surgery, it is very important to evaluate the remnant liver function precisely. And what kind of method are you using preoperative liver remnant function? I mean, ICG, because you should just MERD score or something. And I may have missed, that is number one. And why wouldn't you use autologous vein graft, such as iliac or jugular or left renal vein, for example, for the condyle to reconstruct the vein?
Thank you very much for your question. So the main method of remnant liver function evaluation for us is ICG, actually, and also we look at platelet numbers and all other parameters, including presence or absence of esophageal varices, like the conventional, traditional way that we use. For the reason not using the autologous conduit is the reason that we use this type of direct anastomosis is not because we don't use autologous. The main reason is the length between the anastomosis. So if we use any type of conduit, it makes the distance between the hepatic vein stump becomes longer. Once we put the liver back in, it becomes long. So when we do anastomosis, it looks tight, but after the repurposing, when we put the liver back in, it is quite long, no matter how much we try. So we figured out, regardless of the type of the conduit, it's better not to use conduit. It was our conclusion.
I thought it would be more natural to make it to the original position of the liver. But it's a concept. Thank you.
Are there any comments? I think direct anastomosis is a very good way for such cases. So I'd like to apply in future if we have any case. And how do you select open or minimal invasive surgery for liver resection located in segment 7 or 8?
If we expect that the outcome will be the same, then we prefer to minimally invasive. But in such cases, I don't think we can obtain similar outcome by using minimally invasive technique.
And I think minimally invasive surgery training and education system is very important. How do you do your training or education system in the center?
I think that's a really big challenge for all the training institutions. So for personally, I think it takes a longer time for them to be familiar and confident to do all the procedure. But the best approach is step by step. I have them to start some of the part of the easier part and then expand and then make them do on their own. So it takes a longer time, I guess. Yeah.
Maybe similar in Japan, yeah. No other comments? Oh, thank you, Professor Kim.
Thank you very much.
As Professor Pham mentioned above, the fourth speaker cannot attend this congress, so we'd like to close this session. Thank you for your cooperation.
Thank you very much.
Thank you, speakers and lectures. The next session will start at 10:50, so now we will have a break.